So minimal residual disease is a new goal for us in multiple myeloma. Honestly, we have not previously been able to achieve it, but because we have effective therapies, either combinations of targeted approaches or high-dose therapy with targeted therapy integrated into the paradigm, in either strategy we can achieve minimal residual disease. That means either 1 in 100,000 or even 1 in a million myeloma in normal cells. To date, that assay or that metric has been assayed by either multicolor flow cytometry or gene sequencing. The FDA recently has approved genome sequencing in acute lymphocytic leukemia, but most recently in multiple myeloma for the detection of minimal residual disease. Now we have retrospective data that suggests that attaining a minimal residual disease negative response can predict as a prognostic marker for better progression-free and overall survival. The task for the myeloma community in the future is to determine how to use it clinically first. Should we treat people more aggressively if their initial treatment does not achieve MRD negativity? Should we use consolidation after a stem cell transplant, again, to convert people to MRD negative? Or perhaps most importantly of all, can we inform maintenance treatment? Could we stop maintenance, for example, in someone who is MRD negative? So medically, we're going to now need to utilize this approved test to figure out as a community how it can inform clinical practice. Importantly, we also need to understand how it can be used as a regulatory endpoint. That's so important. Our own success in myeloma is also a problem for us in terms of new drug development. Clearly, a new drug utilized to treat newly diagnosed myeloma at the present time would have to add value to something that already works for 7 or 8 years. So perhaps added to a combination and improve that by 30 or 50%. Honestly, the clinical trial would have to be a decade long. So we can't use progression-free survival any longer as an endpoint. MRD may represent an earlier surrogate marker that might, for example, at 18 months, predict for benefit at 10 years and might allow us to develop novel strategies and novel targeted agents or immune treatments in real time.